Yes, doctor, we can start.
Okay. So good afternoon, everyone. Welcome to pharmacology classes. Today we'll be dealing with an important topic on the glaucoma. So why glaucoma is important? Glaucoma is important because it is the second most common cause of blindness in the world. The first being cataract. So you all know what cataract is. Now we'll be dealing with glaucoma. So glaucoma is actually a condition characterized by increased intraocular pressure. Now, what maintains the intraocular pressure? It is otherwise abbreviated as IOP. So, before going into intraocular pressure, let's see the structures in the eye. So, which are the structures in the eye? We can see the cornea here. We can see the cornea here most anteriorly. Then we will go into a space known as the anterior chamber, which is filled with aqueous humor. Then we have the red colored portion, that is the iris. The iris. Then we have the lens. Now, before the lens, in between the iris, we have a small space that constitutes the pupil. Then we have something called as ciliary body here and certain ligaments suspending the lens. They are the suspensory ligaments. Then we have this blue colored layer is known as the sclera. Then you have the choroid, that is the red colored layer. Then you have the retina. Then you have the optic nerve and disc here. Okay, so we can see the optic nerve exiting. So now this is the anterior chamber, which is filled with a clear fluid known as aqueous humor, and here is the vitreous chamber that is filled with vitreous humor, a gel substance. Now, coming to glaucoma. Now, glaucoma, I told you already, it is caused by raised intraocular pressure. Now, the intraocular pressure normally is maintained by the aqueous humor, and the normal pressure will be about 10 to 21 mmHg, mercury. Now, when do you say it is glaucoma? Glaucoma is diagnosed when the intraocular pressure goes above 21 mmHg. Now, what maintains that intraocular pressure? That intraocular pressure is maintained by the aqueous humor. And where does this aqueous humor comes from? Now, this aqueous humor comes from the ciliary body and the vessels associated with this. Now, if you take a section like this, you can see the iris here. You can see the ciliary body with the ciliary muscles and the suspensory ligament. This ciliary muscle will be ciliary body consists of certain vessels, that is the ciliary vessels. Okay. So the filtration. Now, how does this formation of the aqueous occurs? It occurs by filtration of plasma through the ciliary blood vessels. Now we dealt with the production of aqueous humor. Now, how the aqueous is drained through the eye? We have three main routes. The major route is known as the trabecular outflow. It is the trabecular outflow. Then we have another pathway, that is a minor pathway known as uveoscleral pathway or the uveoscleral outflow. Okay, so you have the trabecular, which is the major pathway, trabecular outflow. Then you have the uveoscleral outflow, which is the minor pathway. Then we have a small amount of that, just said that the small amount of aqueous will also be going back through the iris into the posterior chamber also. So these are the routes. So the main routes we will be discussing here will be the trabecular outflow and the uveoscleral outflow. Okay, so we have dealt with the secretion of the formation of aqueous humor and the outflow of the aqueous humor, that is trabecular and the uveoscleral pathway. Okay, you can see that this is the trabecular pathway. Here it will be the trabecular pathway. Then here you have the uveoscleral pathway. Okay, then yeah, you can see the number one, that is the trabecular outflow. Then you have the uveoscleral outflow. So these are the various parts of the eye associated with the drainage and production of the aqueous humor. And in the trabecular outflow pathway, you have a small canal in here. This at the iridocorneal angle. This is called as this is the iris and this is the cornea. So you have something called as the iridocorneal angle, which consists of a canal known as the Schlemm's canal. Okay, so it will be drained. The trabecular outflow will be through this canal. So this is the two outflow. Now glaucoma. Now what happens in glaucoma is that when the intraocular pressure goes above 21 mmHg, it will ultimately, over a long term, it will produce damage to the nerve, the optic nerve. So it is a chronic progressive optic neuropathy with raised intraocular tension or intraocular pressure. Now the pathogenesis of glaucoma will be either increased. The IOP will be increasing due to either increased aqueous humor production or improper or decreased drainage of aqueous humor. So you have increased aqueous humor production and decreased drainage or decreased drainage of aqueous humor. So how will you treat glaucoma? How will you treat glaucoma? You can either, what are the target, the therapeutic target? You can either target the increased aqueous humor production. So what can you do there? You can decrease the aqueous humor production. Then the improper drainage. What can you do there? You can try to increase the drainage of aqueous humor. So the two main therapeutic targets of glaucoma is to decrease the aqueous humor production and to increase the outflow of aqueous humor. Now, if you take, now this is this, suppose you have the ciliary body. You have the ciliary body. You can see the ciliary body is here. This is your ciliary body. Now, if you take a section of the ciliary body, you can see certain receptors and enzymes here. So these are the, if you take a section, you can see the blood vessels here. Now, these blood vessels will contain alpha receptors, alpha 1 receptors to be specific. Then there are alpha 2 receptors. Now, this is the ciliary body epithelium. Okay, if this is the ciliary body, then this is the ciliary body epithelium with the ciliary blood vessels. Now, this epithelium consists of alpha 2 receptors. So, you have both the alpha receptors here. Then you have beta 2 receptors here. And then you have the carbonic anhydrase enzyme. Let's see the significance of all these. Now, the ciliary body is associated with production of the aqueous humor. Now, this aqueous humor is secreted. I told you already that it is by filtration of the plasma from the ciliary blood vessels. So, that means what has to act there? Which receptors are predominant there? They are the vasoconstrictor acting constrictor, which are the vasoconstriction promoting receptors. They are the alpha 1 receptors. Okay. So, how can you can now this based on this pathogenesis, how can you target the glaucoma? How can you therapeutically treat glaucoma? I told you that there is increased aqueous humor production. That means you have to decrease the aqueous humor production. So how will you decrease the aqueous humor production? By decreasing the amount of blood that is flowing to the ciliary vessels. If you want to decrease the amount of blood flowing to the ciliary vessels, then you have to decrease, you have to produce vasoconstriction. That means you have to use which receptor is promoting a vasoconstriction? It is the alpha 1 receptor. So you have to use alpha adrenergic agonists to promote vasoconstriction, thereby decreasing the production of aqueous humor. Now, what about beta receptors? Now, beta receptors are also there. You can see the beta receptors. Now, beta receptors are also there. So, what will you do? Beta receptors are normally producing vasodilatation. So, that means you don't want vasodilatation here. We want vasoconstrictor property here. So, that the blood will decrease. That is, blood that is forming the aqueous secretion will decrease. So, what can you do here? You will give beta blockers. So, another way to decrease the aqueous humor production is to give beta blockers. So, first one was, the first group of drug was alpha adrenergic agonist. Then we have beta blockers. So, two classes of drugs we have got. Then, any other way to reduce aqueous secretion? You can reduce the aqueous secretion by giving another class of drug that is known as the carbonic anhydrase inhibitors. Now, carbonic anhydrase inhibitors mean, you know that there is an enzyme here, that is the carbonic anhydrase. Now, this enzyme helps in the formation of H2CO3 by the combination of H2O plus CO2, a reversible reaction which is catalyzed by carbonic anhydrase. H2CO3 will be formed and it will split to form H plus and HCO3 minus. Now, this HCO3 minus is associated with important for the formation of aqueous. So, the secretion of aqueous can be decreased by decreasing the generation of HCO3 minus, so that the aqueous secretion will decrease. So, what can you give? You can give carbonic anhydrase inhibitor. So, you have the third class of drugs now. Then, the fourth class of drugs. So, you have three classes of drugs targeting here the increased aqueous humor production. So now you have reduced the aqueous humor production by alpha agonists, beta blockers, then the carbonic anhydrase. Then you have osmotic diuretic or osmotic agents, which are substances which do not exert any action on its own, but what do? They will increase the plasma osmolarity and thereby it is actually used. Osmotic agents are used only in emergency conditions for rapid reduction of the IOT. Now, how do you reduce that? The osmotic agents like mannitol, etc. We'll come to the classification. The osmotic agents will increase the plasma osmolarity, thereby by osmotic action, they will draw water out of the aqueous humor. Okay, so thereby the intraocular tension will decrease. So these are the four classes of drugs that can be used to decrease the aqueous humor production. Now coming to improper drainage or the what do you say, outflow facility. So if there is improper drainage of aqueous humor, you can use drugs to increase the drainage. Now you can use drugs to either increase the trabecular outflow or the uveoscleral outflow. Now the first four classes we dealt with are here. How will you decrease the secretion of aqueous? By using alpha adrenergic agonists, by using beta blockers, by using carbonic anhydrase inhibitors, then by using osmotic agents or osmotic diuretics. Then you have increased drugs which will increase aqueous outflow. So that is by two ways. It can be either by increasing trabecular outflow or by increasing the uveoscleral outflow. So how will you increase trabecular outflow? Now, these are the class of drugs which will increase trabecular outflow. So, you all remember the picture. In the picture, you have the trabecular outflow and the uveoscleral outflow. So, trabecular outflow can be increased by the giving miotics and alpha adrenergic agonists. Remember, alpha adrenergic agonists have all the three mechanisms of action. Okay, so it is common to all the three classes of drugs. But the drug which will increase trabecular outflow are miotics and alpha adrenergic agonists. Both will come there. Now, the miotics, what will they do? The miotics are, what does miotics mean? They will try to constrict the pupil. Okay, suppose this is the iris on both the sides. If both the sides have the iris, then you have the lens here. Okay, lens under that. This is your pupillary opening. Okay, now suppose the iris is like this. Okay, iris is away from the center. That means the pupil is dilated. If the pupil is dilated and iris is away from the center, means you have something here. This is your cornea. Okay, you have the cornea here. Now, if the cornea, if the iridocorneal angle is obliterated. Now, this iridocorneal angle is important. Why? Because it helps in the trabecular outflow. Okay. Now, this trabecular outflow will not happen if mydriatics or if mydriasis is occurring or if the pupil is dilated. Why? Because the iris is away and it is trying to block this angle. If the angle, I will show you in the picture, if the iris moves away and if this angle is blocked, then the flow of aqueous do not take place. Since the major pathway is trabecular meshwork, then the flow of iris will not take, flow of aqueous humor will not take place. So what can you do? Here you can try to move this iris away from the angle by giving what? Meiotics. Meiotics means they both have to come to the center, right? The pupillary constriction has to occur. So the iris will come to the center. This angle will be relieved of the obliteration or the obstruction, and aqueous can flow properly. So that is one mechanism. That is why meiotics are given. Then the prostaglandin analog. Prostaglandin. Now prostaglandins are normally associated with maintenance of intraocular pressure by they will exert their action. They will exert their action on the eye by increasing their intracellular, the remodeling of the extracellular matrix of the smooth muscles of the ciliary body, and thereby they usually, normally in human beings, they will promote the outflow facilities. So you can increase uveoscleral outflow by giving prostaglandin analog. So what are the which are the drugs which are used for glaucoma? We have how many classes? We have alpha adrenergic agonists, we have beta blockers, we have carbonic anhydrase inhibitors, we have osmotic diuretics, then we have meiotic, and then prostaglandin analog. So the drugs used for glaucoma are beta blocker, alpha agonist, alpha adrenergic agonist, prostaglandin analog, carbonic anhydrase inhibitors, and meiotic. Now, which are the beta blockers used? Beta blockers used are timolol, betaxolol, levobunolol, and carciolol. Timolol, betaxolol, levobunolol, and carciolol. Then which are the alpha adrenergic agonists? Alpha adrenergic agonists are dipivefrin. Of course, adrenaline also comes here. Adrenaline, dipivefrin, apraclonidine, brimonidine. Apraclonidine and brimonidine. Okay. Now comes prostaglandin analogs, very important class of drugs. They are latanoprost, travoprost, and bimatoprost. So you have latanoprost, travoprost, and bimatoprost. Then you have carbonic anhydrase inhibitors. Now the carbonic anhydrase inhibitors are dorzolamide, brinzolamide. Okay. Then we have meiotics. The meiotics are pilocarpine, physostigmine, and ecothiopate. Pilocarpine is it's a cholinergic alkaloid, and physostigmine, ecothiopate are the anticholinesterases. Okay. Now, coming to the alpha adrenergic agonist, we use mainly 4 drugs here. We can use adrenaline, dipivefrin, which is a prodrug of adrenaline. Then we have apraclonidine and brimonidine. The adrenaline and dipivefrin are non-selective, but apraclonidine and brimonidine are selective alpha-2 agonists. They are selective alpha-2 agonists. Now coming to the mechanism, they have, I told you already, based on the, you can remember the chart there. That is, you have all the 3 classes, all the 3 mechanisms will be there for the alpha adrenergic agonist. So they will be decreasing aqueous formation, they will be increasing trabecular outflow, they will be increasing uveoscleral outflow. Okay, so this is the mechanism of alpha adrenergic agonist. Now, what about the adverse effects? The important adverse effects. Adrenaline will cause black pigmentation of conjunctiva. Remember, it is not anywhere else, it is the conjunctiva. So it will cause black pigmentation of the conjunctiva. That is caused by adrenaline or epinephrine. Then you have the apraclonidine. Apraclonidine and brimonidine, which are the selective one. The apraclonidine, the name contains LID, that is a lid. So it will cause lid retraction. Okay, it will cause lid retraction. Then comes the brimonidine. Brimonidine will cause CNS depression and apnea in neonates. So that means it will produce CNS depression or brain depression. BR is highlighted here. So it will cause brain depression or CNS depression and apnea in neonates and infants. So it should not be used in infants. Okay. So these are the alpha adrenergic agonists. Then beta blockers. Coming to the next class, beta blockers. Now, beta blockers were initially used as the first line drugs. Now, the latanoprost and the prostaglandin analogs are the first choice drugs in glaucoma. Now, what do the beta blockers do? They will lower the intraocular tension by decreasing aqueous formation. We already know that aqueous formation will be decreased by alpha agonists, beta blockers, osmotic and osmotic diuretics, and also the carbonic anhydrase inhibitors. Then, so what do? They will cause down regulation of the adenylyl cyclase by beta 2 receptor blockade in the ciliary epithelium. We already saw that there is a beta 2 receptor in the ciliary epithelium. Now, what are the adverse effects? Adverse effects are locally they will cause stinging, redness, hypoesthesia, and blood vision. Okay, so all the local symptoms will be there. That is stinging, redness, hypoesthesia, and blood vision. Now, what about the systemic adverse effects? Of course, beta blockers will cause all the adverse effects that starts with B. So it will be bronchial asthma or bronchospasm, then bradycardia, then block, that is heart block. So all of them are starting with B. So beta blockers will cause bronchospasm or bronchial asthma, bradycardia, and heart block, and congestive exacerbation of congestive cardiac disease. Then, now which are the beta blockers? We have non-selective beta blockers and selective beta blockers. So just like the previous class of drugs, we have the non-selective and selective one. Non-selective is acting on both beta 1 and beta 2 receptors. They are the timolol, levobinolol, carciolol, and metipranolol. Timolol, I repeat, timolol, levobinolol, carciolol, and metipranolol. Now, which are the cardioselective ones which can be used for glaucoma? That is beta-axolol. That is a beta 1 selective beta blockers. They are the beta-axolol. Both of them will decrease aqueous production. Adverse effects are, one more adverse effect will be there, that is blepharoconjunctivitis. So it will produce blepharoconjunctivitis, bronchial asthma, then bradycardia and block. Okay, heart block. Now with the beta-axolol, that is a beta selective, beta 1 selective, there are lesser adverse effects. Okay, especially the bronchospasm will be lesser. So it can be safely used in asthmatic people. Now coming to miotics, that is the third class miotics or otherwise cholinergics. Now this class of drugs consists of mainly alkaloids like pilocarpine. Then you have anticholinesterases like physostigmine and ecothiophase. Now, what do they do here? Look at the picture here. This is your pupil. Now, surrounding the pupil, you have the sphincter pupillae muscle. Okay, they have this concentric bands will be sphincter pupillae muscle. Remember, they are associated with contraction of the pupillae. Now, how do they do this contraction? They will do this by, now suppose these are the circular concentric rings. You have the pupil in the center. Sorry, the pupil will be formed by this contraction of these sphincter pupillae muscles. Now, for any muscle to contract, there should be acetylcholine. So, the acetylcholine receptors, M3 receptors are present on the sphincter pupillae. So, when the M3 receptors are activated by the acetylcholine, because pilocarpine is given, it is a cholinergic drug. Then physostigmine will inhibit breakdown of acetylcholine. So what happens? They will act on the M3 receptors. When the M3 receptors are stimulated, they will contract towards the center. Thereby, the pupil size will decrease or there will be pupillary constriction. Whereas you have the dilator pupillae here, they will be relaxing. Okay, they don't have much action. Now, if it is the opposite, if it is mydriasis, means these radial muscles, okay, radial muscles or the dilator pupillae muscles, which are like the spokes of the wheel, they will pull outward. Okay, when they are contracting in order to increase the size, as in the opposite case. Okay, you don't have to deal with that here, but I'm just comparing. When it is mydriasis, these muscles will be pulling out. These radial muscles will be pulling out, constricting, okay, so that it will open up. Whereas in the case of sphincter pupillae or in the case of pilocarpine or miotics are given, these sphincter pupillae will constrict the pupil. All the circular muscles will constrict the pupil. Now, what happens when the pupil is constricted? I already told you that suppose this is the iris. This is your iris, okay? It is like this. You have the lens here in the center, okay? You have the pupil. the pupillary size will be, the pupillary opening will be here. Okay. Suppose if it is like this, this is mydriasis. If it comes towards the center, it is the meiotic. So if it is meiosis. So when there is meiosis means what happens? The iris is moving away from the iridocorneal angle. This angle obliteration will be relieved. So aqueous can flow outward to the trabecular pathway. So that's how the meiotics and the cholinergics will help in glaucoma. So which are they? Which are the meiotics used? We have directly acting meiotics, which are pilocarpine. Then anticholinesterases like physostigmine and ecothiophate, they will increase the trabecular outflow. Now, what you have to note here is that the adverse effects are unique in that they will produce brow ache. The most important you have to remember here is the brow ache and blurred vision and spasm of accommodation. Remember, these muscles are being made to contract because of the action of pilocarpine and the physostigmine. They are made to contract and stay like this. So when they are staying like this, the tone will be increased and there will be spasm of accommodation. Okay. So because they are made to contract like this, stimulated and contract like this, it will cause pain to the muscles surrounding the eye. So it will be resulting in headache, brow pain and spasm of accommodation. Okay. So that is regarding meiotic. Then coming to the most important class, that is the prostaglandin analogs. Now, prostaglandin analogs means the prostaglandin, the PGF2 alpha specifically will reduce intraocular tension. Normally in our eye, prostaglandins act to reduce intraocular tension by enhancing normally uveoscleral outflow. So, if you give prostaglandin analogs like latanoprost, bimatoprost, travoprost, and tafluprost, what happens? They will enhance the uveoscleral outflow. So, which class of drugs are enhancing the uveoscleral outflow? If they ask you, it is the prostaglandin analog, or it may be in the option, it will be given latanoprost, bimatoprost, travoprost, etc. Now, what are the important adverse effects of prostaglandin analogs, especially the latanoprost? They will cause pigmentation of iris. Now, don't confuse. Conjunctival pigmentation is caused, black pigmentation of conjunctiva is caused by adrenaline or epinephrine, and the iris pigmentation was induced by latanoprost. Then they will induce growth of eyelash because of the increase in blood flow and aqueous flow. They will induce growth of eyelashes, or they will cause hypertrichosis. So it can be used for enhancing growth of eyelashes also cosmetically. So, growth of eyelashes, then macular edema. So, what are the adverse effects of latanoprost or prostaglandin analogs? They are pigmentation of iris, growth of eyelashes, and macular edema. The advantages of latanoprost. Now, why do we prefer latanoprost now is that it can be given once daily. Okay, once daily administration is enough, and there are no systemic adverse effects like beta blockers, etc., which were initially the first choice drugs. So they don't have much adverse effect, systemic adverse effect, but only disadvantage is it has high cost, it's expensive. Okay. So the prostaglandin analogs are latanoprost, bimatoprost, travoprost, and tafluprost. Okay. Then coming to carbonic anhydrase inhibitors. Now already told you that the carbonic anhydrase.
Sorry to interrupt. Actually, we are running out of time. More or less, we have understood. I mean, they have understood like how you teach. Can you please go to the MCQ part and
yeah. Yes. Okay.
Yeah.
So coming to MCQ, please solve with MCQ. Now, which of the first question, which of the following anti-glaucoma drugs is unsafe in infants? Now, can you please answer these questions? Which of the following anti-glaucoma drugs we discussed till now, of that, which of this is unsafe in infants? Okay. So, you have 4 options, that is timolol, brimonidine, latanoprost, and dorzolamide. So, timolol is a beta blocker. Then you have alpha adrenergic agonist, that is brimonidine. Then you have latanoprost. Then you have dorzolamide. It's a carbonic anhydrase inhibitor. So, which of these will be used for, which is unsafe in infants? We have already discussed the adverse effects of alpha adrenergic agonist. So what did we say there? DR or brain suppression or CNS depression is caused by which drug? That is brimonidine. So brimonidine is actually, it is unsafe to give in neonates and it will cause apnea. Okay, it will cause apnea in infants and neonates. Now coming to the next question. Which drug is contraindicated in a glaucoma patient suffering from bronchial asthma? So the options are timolol, timolol maleate, latanoprost, betaxolol and brimonidine. So among these four options, which is not to be used in a person with glaucoma in bronchial asthma? Yes, the option is timolol because it is a non-selective beta blocker which will act on both beta 1 and beta 2 receptors and it will precipitate the bronchospasm. Okay, so it is not to be used in bronchial asthma patient. Now, which of the following anti-glaucoma drugs, third question, which of the following anti-glaucoma drugs is likely to cause black pigmentation on conjunctiva? Okay, we have already dealt with that. So, which one causes black pigmentation on conjunctiva? We have four options, that is timolol, latanoprost, adrenaline and pilocarpine. All the classes of drugs are there. Yes. Yes, it is caused by adrenaline and adrenaline or epinephrine. The mode of action. Fourth question, the mode of action of latanoprost in glaucoma is, it will, first option, decrease aqueous production, B, decrease UV scleral outflow, C, increase UV scleral outflow, D, increase trabecular outflow. So which one of these is correct? It will increase uveoscleral outflow. So that's all about today's class.
Yeah.